Hello everyone, my name is Crystal Alcantara, and the disease category I will be covering is eye disorders. This presentation will focus on the research for complementary therapies for cataracts. Eye diseases are characterized by the problem of visual impairment. According to the American Academy of Ophthalmology, individuals with visual impairment are at higher risk for chronic health conditions, accidents, social withdrawal, depression, and mortality. Common eye disorders that cause vision impairment are refractive errors such as nearsightedness or farsightedness, cataracts, age-related macular degeneration, diabetic retinopathy, and glaucoma. Due to an overall aging population, the number of people with visual impairment and blindness is increasing. According to the CDC, approximately 12 million people, 40 years and over in the US have vision impairment. Vision impairment is associated with the increasing epidemics of diabetes and other chronic diseases, with the number of Americans aged 40 years and older suffering from uncorrectable vision impairment estimated to rise to almost 9 million by 2050. Annual economic impact is estimated to be greater than $145 billion, which includes direct costs and lost productivity. Cataracts are a leading cause of visual impairment among aging Americans and are interpreted to be a key quality of life issue. Cataracts are characterized by the cloudiness of the lens of the eye that causes a decrease in vision, which may lead to eventual blindness if left untreated. According to the American Academy of Ophthalmology, worldwide, cataracts are the #1 cause of preventable blindness. Cataracts are diagnosed by dilated eye exam, in which a doctor gives a patient eye drops to dilate or widen the pupil, and then checks the eyes for cataracts or other eye problems. Common complaints associated with cataracts include blurry vision, difficulty reading in low light, poor vision at night, glare around lights, and occasionally double vision. While there is no medical treatment to prevent the development or progression of cataracts, there is the definitive treatment of modern cataract surgery. Cataract surgery is characterized by the removal of the cloudy lens and implementation of a clear lens. Cataract surgery is the most effective and most common procedure performed in all of medicine, with an overall success rate of 97% or higher. Cataracts are well known to be associated with increased age. More than half of all Americans aged 80 or older either have cataracts or have had surgery to get rid of cataracts. According to the National Eye Institute, in 2010, white Americans aged 40 and older had the highest prevalence rate of cataract at 18%, followed by Black Americans at 13%. Hispanic Americans had the lowest rates of cataract at 12%. In regard to gender discrepancies, in 2010, 61% of Americans with cataract were found to be women. Risk factors for cataracts include diabetes or hyperglycemia, smoking, UV light exposure, ocular diseases, ocular trauma, genetic predisposition, and steroid use. Rain and their co-authors estimated the societal economic burden of a multitude of visual disorders among U.S. adults aged 40 years and older, and found that in 2004, the direct medical cost for cataracts was roughly $6.8 billion. When the lens of the eye, which are normally clear, become opaque, this is called cataract. The lens of the eye is comprised of a natural crystalline material with proteins and water that create transparent structure that allows light to pass through. Opacity occurs when the crystalline proteins clump together, causing the lens to thicken and harden. Vinson reports that lens opacity is a direct result of oxidative stress in a study on the pathophysiology of cataracts. He highlights that cataracts occur primarily due to age, related to depleted antioxidant reserves, diminished antioxidant enzyme capabilities, and decreased proteases. He emphasizes that UV light and tobacco are both well-known oxidative stressors, and that we are more susceptible to UV light damage as we age. Lastly, he reviews oxidative damage as a result of hyperglycemia as a common occurrence in cataract development. This is characterized by superoxide, a free radical in the mitochondria of the eye, being elevated as a result of high blood sugar levels. The first therapy I will be evaluating is lutein. Lutein is a phytochemical that falls into the family of nutrients called carotenoids, known for providing color pigments in many fruits and vegetables. Lutein is often referenced in the literature with zeaxanthin, another carotenoid. They are both the only carotenoids detected in the human lens and act as natural antioxidants in the eye. Common dietary sources of lutein include leafy green vegetables like kale, spinach, broccoli, and peas, and lettuce, as well as egg yolks. Its role in human health, and particularly in eye health, is well established from epidemiological, clinical, and interventional studies. Along with zeaxanthin, lutein has demonstrated the ability to act as a scavenger for reactive oxygen species and to bind with physiological proteins in humans. For these reasons, lutein as well as zeaxanthin are popular additions to numerous supplements marketed for healthy vision. In this first study, which is a long-term supplementation study over a 36-month period, Olmadia and her co-authors explored the effect of lutein supplementation on patients with cataracts and age-related macular degeneration. Participants included 10 subjects, all non-smokers between the ages of 55 and 75, who were clinically diagnosed with cataracts or age-related macular degeneration. 3 lutein capsules derived from marigold flowers with 15 milligrams total lutein were provided each week. Concentration of each lutein capsule were comparable to that contained in 100 grams of spinach. Visual outcome was measured using routine clinical and diagnostic tests. The researchers in this study found that in patients with cataracts, changes in serum concentrations of lutein and improvements in visual acuity occurred at the same time, and that visual acuity improved in all subjects with cataracts. Some limitations of the study include varying bioavailability of carotenoids, small sample size, short duration, consideration of 2 different age-related eye diseases, and lack of randomized control or placebo use. In terms of safety, no significant side effects were reported by the subjects, and no changes were observed in their biochemical or hematological profiles. In the second study, Olmadia and her co-authors, now in a double-blinded, randomized, placebo-controlled study, looked at the visual effects of lutein supplementation on 17 subjects clinically diagnosed with cataracts. Participants were provided with dietary supplementation of either 15 milligrams lutein, 100 milligrams alpha tocopherol, or a placebo 3 times a week for up to 2 years. Like in the first study mentioned, concentration of each lutein capsule were comparable to that contained in 100 grams of spinach. Visual performance and biochemical and hematological indexes were monitored every 3 months throughout the study. The results showed that statistical significance was reached only in the lutein group, with antioxidant supplementation yielding a significant improvement in visual performance. The authors found that long-term lutein supplementation at nutritionally achievable levels is effective for reaching and maintaining serum lutein concentration, which in turn can improve the visual performance of patients. Some limitations of the study include high dropout rate, especially of those in the placebo group, small sample size, and bioavailability of the carotenoids. Similar to the first study, no significant side effects were observed in any subject throughout the study. This third and final study on lutein supplementation is currently the largest clinical trial investigating carotenoid supplementation in cataract progression. As a secondary goal, the Age-Related Eye Disease Study 2 research group evaluated the effect of lutein and zeaxanthin on the progression of age-related cataract in 4,203 participants aged 50 to 85 years old, at risk for progression to advanced age-related macular degeneration. Participants were randomly assigned to a daily placebo. These include lutein or zeaxanthin at 10 milligrams and 2 milligrams respectively, omega-3 long-chain polyunsaturated fatty acids at 1 gram, or a combination to evaluate the effects of the primary outcome of progression to advanced age macular degeneration, or the secondary effects on the secondary outcome of progression to cataract formation. Results from the study revealed that lutein and zeaxanthin supplementation yielded neither beneficial or harmful effects on the rates of cataract surgery or moderate vision loss. A major implication for the study would be whether supplementation would be beneficial for a less well-nourished population. Some limitations of the study include high dietary intake of lutein and zeaxanthin, better nourished participants in general, timing and duration of the use of supplements, and pre-existing cataracts that were not apparent at the start of the study. There were no clinical or statistically significant serious adverse effects associated with the provided treatments. Overall, the results of the 3 studies discussed are variable due to the limited number of randomized controlled trials to support the role of lutein supplementation in the prevention of cataractogenesis. In my efforts to find research, many studies were focused more on lutein, often in conjunction with zeaxanthin, supplementation in the prevention of macular degeneration and not in the prevention of cataracts. And most of the studies were observational or cohort-based, such as the first one that I reviewed. The body of research investigating lutein supplementation and cataract formation is just not well established. The 2 randomized controlled trials I included yielded conflicting results. It is important to note that Study 2 by Olmadia and her co-authors had many limitations, whereas Study 3 by the age-related eye disease Study 2 group did not, despite them both being double-blinded, randomized controlled trials. Results from Study 3 had many strengths, including a 5-year follow-up period, standardized data collection, and good compliance, so the major result of there being no effect of lutein supplementation on cataract surgery or vision loss related to cataract progression is well qualified. Concerns found in the 3 studies presented to be considered in future trials include the bioavailability of the different carotenoids used, adequate number of participants, adequate study duration, consideration of multiple diseases in a study at one time, timing of supplementation in the timeline of disease process, and prior as well as current dietary intake levels of participants. Of note, there were no adverse side effects or safety issues noted in any of the studies mentioned. Overall, lutein supplementation does not have a significant effect on rates of cataract formation or progression. The second therapy I will be evaluating is vitamin E. Vitamin E is a fat-soluble or lipid-soluble vitamin that offers many antioxidant properties. It is commonly found in nuts, nut butters, vegetable oils, fortified cereals, and sweet potatoes. Vitamin E is responsible for adequate immune function, healthy cell membranes, and DNA repair. The human body does not create the vitamin E it needs to support the wide range of metabolic processes it plays a crucial role in, so intake through diet or through nutritional supplementation is crucial. It has been found that in most Western diets, vitamin E is low. Similar to lutein, vitamin E is said to support good eye health via its protective antioxidant properties. Deficiency is characterized by nerve damage, muscle weakness, poor coordination, involuntary movement of the eyes, and red blood cell breakage, which can lead to anemia. McNeil and his co-authors conducted the vitamin E cataract and age-related maculopathy trial, a prospective randomized double-masked placebo-controlled trial to determine whether treatment with vitamin E reduces either the incidence or rate of progression of age-related cataracts. 1,193 participants with early or no cataracts aged 55 to 80 years old were enrolled and followed for up to 4 years. Subjects were assigned randomly to receive either 500 IUs of natural vitamin E and soybean oil encapsulated in gelatin or a placebo. Overall, 875 of the study participants completed the 4 years of follow-up. The study found that vitamin E given for 4 years at a dose of 500 IUs daily did not reduce the incidence of or progression of any type of cataract. Some limitations encountered during the study include high dosage amount, duration, confounding by other lifestyle factors such as diet and socioeconomic status. In terms of safety, overall, 678 people reported at least one adverse event. However, there were no consistent or unusual patterns identified among reports. In a randomized, double-masked, placebo-controlled trial, Kristen and his co-authors investigated whether vitamin E supplementation decreases the risk of age-related cataract in women. The study assessed 39,876 apparently healthy female health professionals aged 45 years or older. The participants were randomly assigned to receive either 600 IUs of natural source vitamin E on alternate days or a placebo. Results of the study showed no significant difference between the vitamin E and placebo groups in the incidence of cataract, therefore suggesting that there is no benefit of vitamin E supplementation for cataracts. Some limitations of the study were inclusion of the participants with prevalent lens opacities at the start of the study, potential barrier effect in those aged 45 years and older, bias in the ascertainment of cataracts at the end of the study, and poor compliance. No safety issues or side effects were reported. In this final study, Kristen and his co-authors again conducted a randomized, double-masked, placebo-controlled trial to test whether supplementation with alternate day vitamin E or daily vitamin C affects the incidence of age-related cataract in a large cohort of men. The participants in the study included 11,545 apparently healthy U.S. male physicians 50 years or older without a diagnosis of cataract at baseline. They were randomly assigned to receive either 400 IUs of vitamin E or placebo on alternate days and 500 milligrams of vitamin C or placebo daily. Results show that long-term use, or in this case, over the span of 8 years, of vitamin E and C supplements has no significant effect on cataract. Again, Kristen and his co-authors found no significant beneficial or harmful effect of supplementation on the risk of cataract. Limitations of the study include homogeneity of participants in that they were again a generally well-nourished population, provision of supplement doses greater than usual dietary intakes, form of vitamin E used, and duration and timing. No safety issues or side effects were reported. The body of research on vitamin E supplementation and eye-related diseases is well established. However, in my search for studies, it was difficult to find many studies that included only vitamin E in their treatment, hence why the third study I included by Kristen and his co-authors is a trial that includes both vitamin E and vitamin C. The consensus among all three of the studies I investigated is that there is no benefit of vitamin E supplementation for risk or prevention of cataracts. Protocols between the three presented studies varied in dosage amount, source of vitamin E, study duration, and provision of additional supplement, namely in study 3, evaluating the effects of both vitamin E and vitamin C. Similar limitations to the lutein studies were found, including participants being generally well-nourished, which relates to confounding factors of better diet quality and socioeconomic status, adequate study duration time, and timing of supplementation in the timeline of disease process. Some additional limitations presented in these studies include high dosage amounts, levels of oxidative stress in participants at baseline, age of participants, bias in the identification of cataract endpoints, and source of vitamin E used. Of note, there did not appear to be adverse side effects or safety issues noted in any of the studies mentioned. Overall, vitamin E supplementation does not have a significant effect on rates of cataract formation or progression. In summary, I would not recommend either lutein or vitamin E supplementation to prevent the development or slow the progression of cataracts based on the current body of research available. Issues in the studies analyzed that ought to be considered in future trials include standardized dosing, source of the nutrient, adequate study duration time, adequate sample size, and prioritizing just one eye-related disease in one study at a time. Some research implications for future trials include investigating the role of carotenoid and antioxidant vitamins and minerals on individuals and groups at higher risk for oxidative stress, such as smokers, diabetics, or those with poor nutrition. Other therapies of interest that should be considered in future clinical trials include other phytochemicals, as they may play a role in alleviating ocular oxidative stress. Bungua and their co-authors emphasize anthocyanin, ginkgo biloba, quercetin, and resveratrol specifically, as they have proven antioxidant and anti-inflammatory activities that may benefit diseases caused by oxidative damage and oxidative stress. Mock and their co-authors further describes the potential antioxidant effects of the specific polyphenol anthocyanin derived from the seed coat of black soybean and the prevention of lens epithelial cell damage and thus cataract risk.